Paul, my mom's sister once took Ritalin instead of aspirin. It really upped the ante.
It's not bad.
Not bad.
The Curbsiders podcast is for entertainment, education, and information purposes only, and the topics discussed should not be used solely to diagnose, treat, cure, or prevent any diseases or conditions. Furthermore, the views and statements expressed on this podcast are solely those of the host and should not be interpreted to reflect official policy or position of any entity, aside from possibly Cash Like Moral Hospital and affiliate outreach programs, if indeed there are any. In fact, there are none. Pretty much, we aren't responsible if you screw up. You should always do your own homework and let us know when we're wrong.
Welcome back to the Curbsiders. I'm Dr. Matthew Frank Watto, here with my great friend and America's primary care physician, maybe the primary care physician, Dr. Paul Nelson Williams. Hi, Paul.
Hi, Matt. How are you?
I'm doing well. This is a Hotcakes / Digest episode. So we have with us two great guests, Dr. Rahul Ganatra and Dr. Nora Taranto. And Paul, before we start talking with our good friends, how about you remind people, what is it that we do on the Curbsiders? What will we be doing on this episode?
Sure, Matt. As per usual, we are the internal medicine podcast. We usually use expert interviews to bring you clinical pearls and practice-changing knowledge. Every so often, we like to do a deep dive on articles that we think are interesting or noteworthy or practice-changing. Oftentimes, they are featured in our own Curbsiders Digest, which recaps the latest practice-changing guidelines and news in internal medicine. And then some of them are just articles that we found interesting that we thought that are worth talking about and that we can maybe make a bad joke or two about. So we'll do some critical appraisal, do some reviews, try to keep you up to date, and try to get this under 2 hours, but we'll see how it goes.
It'll be shorter than that. So we're going to talk about PCI. We're going to talk about aspirin for fatty liver, whatever we're calling that nowadays, reversal of intracranial bleeding, a new antibiotic for UTIs, Naltrexone for people with cirrhosis, a lot of stuff. I didn't even name it all there. So we're going to get to it. And before that, I want to remind you that this and most episodes are available through VCU Health for CME for all health professionals at curbsiders.vcuhealth.org. And also, if you haven't done so yet, sign up for our Patreon at patreon.com/curbsiders, where you can get bonus episodes, ad-free episodes, access to our Cash-like vault, and a whole bunch of other cool stuff. So check it out at patreon.com/curbsiders. And I think we're ready now, Paul. You think we're ready to start?
I am so ready, Matt.
This first trial is the Prevent trial. This is by Park et al. It appeared in The Lancet in 2024. Paul, preventive percutaneous coronary intervention versus optimal medical therapy alone for treatment of vulnerable atherosclerotic coronary plaques. Prevent. I don't know how we got Prevent out of that, Paul. What do you think?
I think it's impossible that there hasn't already been a Prevent trial. Like, that doesn't even seem... That's the part that is mind-blowing. Yeah, the fact that they tortured those words into an abbreviation, Prevent, is not surprising to me. But the fact that Prevent has not been done before is...
So I think Prevent is a cool name for a trial. I agree. It's shocking that maybe there probably was. I didn't look to see if there was another Prevent trial. But Nora, Paul once revealed to us that he doesn't care about the word they use. He cares about whether or not they correctly use the acronym.
Which, yeah, I feel like the word is like 99% of the money there. So this
Paul,
one seems good to me.
Nora, you may be someone who's making big trials in the future, right? So you pick a cool word, then you cram an acronym into it, right? Isn't that the way to go?
Exactly. You just capitalize random letters in the word, and then somehow it comes together.
No, this is why mortality is up in this country. This is why people are dying, is because we're being too lazy to reverse engineer the words that we like into proper trial names and just kind of forcing things in there. Like, I'm not saying the authors of this article are lazy. I will suggest that the person who came up with the name might be.
Okay, well, this was the Prevent trial was covered by Jen DeSalvo in Digest number 53. And what the authors were looking at is, does optimal medical therapy with PCI perform better than optimal medical therapy alone when you're looking at non-flow limiting, high-risk, vulnerable plaques? So flow-limiting plaques have this FFR that they look at. And if that's less than 0.8, that's considered flow limiting. Numbers above 0.8 are considered non-flow limiting. So they wanted to try to say, like, okay, so for these non-obstructive coronary lesions that have this like thin cap and a large necrotic core that we think are the cause of coronary events, if we stent those preventively, can we prevent major adverse cardiac events? Now, the history, there's a Courage trial by Bowden and et al. In 2007 that looked at PCI versus optimal medical therapy, and it did not find a benefit with PCI. And they were looking at stable coronary disease in that population, which is similar to the population we're talking about here, but they weren't specifically looking at vulnerable plaques. And then, Paul, there was the FAME-2 trial and there was the Orbita trial. The FAME-2 was a little bit more favorable towards PCI. The Orbita trial was really not favorable towards PCI when we were talking about anginal symptoms. So it's still kind of up in the air. And this was a positive trial, and the outcome was a primary outcome. And it was death from cardiac causes or MI or need for revascularization of the target vessel, meaning the vulnerable plaque, the vessel with the vulnerable plaque, and then, or someone hospitalized for basically acute coronary syndrome. And they reported for the intervention group at 2 years, it was significant. There was a 3% reduction, absolute difference of 3% reduction in the treatment group, the PCI group. And that seemed to hold at 4 years and 7 years of follow-up. So with that being said, comments, questions, concerns?
Yeah, I would love to know more about how the study was carried out, Matt. I mean, for any positive trial, I always start by thinking, okay, what are the sources of chance and bias that could threaten our interpretation of those results? In your reading of the study, in terms of how the study was done, or who were the patients, were there any things that sort of stuck out as far as causes of concern that could explain that positive finding?
Sure. So this was a randomized trial, and it was done in a couple countries in Asia, also New Zealand, but it was open label. But it was done at 15 different research hospitals. Patients were adults. I already told you they had non-flow limiting coronary disease, and they were using intracoronary imaging to determine which were these vulnerable plaques with that thin cap and large necrotic core. And they screened 5,600 plus patients, but only 1,600 were enrolled. So that's about 28.6% of those who were screened. And there were 800 in each group. So 800 got PCI plus medical therapy. The other 800 got just medical therapy. And they followed everybody for at least 2 years. The maximum follow-up was 7 years for people that were enrolled earlier. And these were patients in their 60s. They had like the normal, most of them had stable angina, and then they had high blood pressure, high cholesterol, and some other comorbidities scattered. But it was a pretty representative population of what I would see other than it being in Asia and New Zealand. And then I would say what jumped out at me to what could have introduced sources of chance and bias were the open label design. There was a very small number of events at 2 years, which was the primary outcome, like the primary time point they looked at. There were only 3 events in the PCI group compared to 27 events in the optimal medical therapy group. So, Rahul, those were the big ones that jumped out to me. Any that jumped out to you?
Yeah, I mean, it's always good to think about the assessment of outcomes. The party line about a trial that is open label is that tends to introduce sources of bias when the outcome is more subjective, or when the assessment of the outcome, could be influenced by the investigator's knowledge of group allocation. I would hope that the elements of their composite outcome here would be things that would be pretty objective and hopefully not influenced by the knowledge of the trial group. But you could imagine if you knew that you had a procedure done, maybe that would influence your, perception of chest pain or reporting. And we know from studies like the Orbita trial that, there is some therapeutic effect of undergoing a procedure. So, that could very well be relevant in this case.
Yeah, because the composite outcome had that significant effect. But when you look at like death from any cause, the confidence interval crossed 1. And when you look at MI, the confidence interval crossed 1. But the only one that was significant was revascularization. So you could see how like the person's like, oh, I know I didn't have a stent. So maybe those people were more likely to go for them. And that's why they were able to see a difference in that outcome. I'm not sure. So I don't think it's definitely not a perfect trial. And you could see, of course, this was industry funded, like people that made the intravascular imaging devices and things were funding this. So I know they wanted this to be a positive trial. And I think we should all want it to be a positive trial because this would be good to prevent more things. But unfortunately, the big ticket item of like death from any, cardiovascular death from any cause, MI, wasn't as significant as I would like it to be. So I feel like we'll see this looked at more, but I'm not sure that I would just go recommending this to everybody. And I feel like your local cardiologist would have to be able to do this coronary imaging in order to really enact it. And I think that's probably one of the limiting things for it. But I think people are just going to read the headline that like preventive PCI is now a thing. And then are we just going to be stenting everything? Paul, you think that's going to happen?
Well, I think we'll try. It's interesting, Rahul, when you mentioned the potential of bias. Like, it didn't even occur to me of that influencing how you would determine outcomes. But I wonder, like, to the point of patients feeling better after procedures, or just I got some stuff in there, I better take care of myself, or even what optimal medical therapy looks like for someone that has had an intervention in subtle ways. Like, I'm sure everyone was on a statin and that kind of stuff. But is there a possibility that if you know that your patient was stented, you maybe go for tighter blood pressure control or better glycemic control, or just lecture them a little bit more? I don't know. I'm just sort of presupposing here, but I feel like just knowing your patient has been through the intervention may impact both how they behave and even how you treat them to some extent, possibly.
Right. And they did comment on how the patients who underwent PCI, greater proportion were on dual antiplatelet therapy, which makes sense. So I do think there are some differences in terms of medical management noted. And then I think they were all on similar doses and intensities of statins. But I think in the discussion, they commented on kind of, is the preventive helpful effect of the stent could it be equivalent to just being on a high intensity statin? Because I think not that many of the patients were actually kind of equivalently on high intensity statins. So it's an interesting question.
I've kind of given my bottom line on this is I think, while it's a positive trial, I think it's interesting. I think it might be hard to implement. I will give this a 3, 3 hotcakes, Rahul, not 4 or 5, because I do think there were some limitations to this, and I'm just not sure what the real world implications are going to be. And I'm worried that this will swing the pendulum back towards like more unnecessary stenting, which I know at some point people were just going stent crazy. Now, now it's kind of, I feel like, a little bit more reasonable recently. So we'll see. But we should move on to the next one, which is another really great trial with a really great name. So Rahul, you want to tell us about that?
Of course. I would just love to tell you about the Andexanet trial. This was a paper that was published by Connolly and colleagues in a May 2024 issue of the New England Journal of Medicine. And before we talk about the paper, the trial abbreviation, you're going to just be tickled. Andexanet Alfa, a novel antidote to the anticoagulation effects of factor 10A or FXA inhibitors. Paul?
Not bad. I mean, it's
that one just slides right through. Wow.
Yeah. I might have a grudge against cardiologists, to be honest. Yeah.
All right. So what was the research question that these authors sought to assess? Well, these authors were seeking to assess the safety and efficacy of Andexanet Alfa compared with usual care among patients with DOAC-associated intracerebral hemorrhage. So why is this study important? Well, although DOACs are thought to lead to less intracranial bleeding than vitamin K antagonists like warfarin, the lack of targeted reversal agents is part of why the morbidity and mortality of intracranial bleeding while on DOACs, when it does occur, remains high. And Andexanet Alfa is a new kid on the block. It's a recombinant inactive form of factor 10A, which is essentially a decoy that binds up any factor 10A inhibitor molecules that are present and leads to rapid restoration of factor 10A activity and hemostasis. And it's shown some promise in reducing hematoma expansion in an uncontrolled study from the same group, the Annexa-4 trial, but it had not yet been evaluated in a randomized controlled trial. So what were the top-line findings of this paper? Well, this was technically a positive trial with respect to the primary outcome. The authors found that among patients with intracerebral hemorrhage on a DOAC, Andexanet Alfa, when compared with usual care, was associated with a 13% absolute increase in hemostatic efficacy. So let me tell you what hemostatic efficacy is. Composite endpoint, defined as hematoma expansion of no more than 35% of the initial size, a worsening of the NIH stroke scale score of no more than 7 points, okay, and no requirement for rescue therapies within the first 12 hours after administration. So positive trial with respect to the primary outcome. However, There were no differences between groups in deaths or neurologic function at 30 days, although the trial was not powered to assess these. But there was an absolute increase in thrombosis of about 5%. And these were primarily ischemic strokes in patients who received the study drug.
Paul,
So I'm
that sounds
curious.
bad.
Yeah, I feel like as a general rule, I try to avoid giving my patients strokes. So I'm excited to hear more.
Yeah, I didn't even have an opportunity to ask what people thought about that because that's kind of obvious that that's bad. Okay, so let me tell you a little bit more about how the study was done, and then we can talk about the details a little bit. So the way that this worked was patients presenting to study hospitals with an intracranial hemorrhage below a certain size and without severe neurologic deficits were randomized 1-to-1 to get Andexanet Alfa, either as an initial low dose or a high dose bolus, and the dose depended on the type of DOAC they were receiving, the dose, and the timing, how recently they had received it. Had to have received it within the past 15 hours. And then they got a continuous infusion for 2 hours of the study drug after that, or usual care. And basically what usual care was 85% of the patients in the usual care group ended up getting PCC. And the primary outcome was assessed at 12 hours, and neurologic outcomes and deaths were assessed out to 30 days. So who were the patients in this study? 550 adults, mean age in the upper 70s. Out of that 550, 20 patients were removed actually due to problems with consent that were uncovered later. And so the safety analysis was done in 530 patients and the efficacy analysis done in 492. Most frequent DOAC used was apixaban. The median hematoma size was 10 mLs, which I've never thought about hematoma size before. The median NIH stroke scale score was 9, and bleeds were preceded by trauma in 10 to 15% of patients. So I'm curious if people have questions or thoughts at this.
Yeah, Rahul, I had a question. So the primary composite outpoint, you mentioned a little bit of this, but what was driving this to be a positive trial? Because that's what I always look at when you see a composite, and if it's like, it's usually the endpoint in the composite that I care least about that tends to be driving it. I'm like, so do I really care about this trial or not?
Yes. So looking at table 2, where they should list the components of the primary outcome for any composite outcome, you can see that the hematoma volume change of less than 35% was really sort of what drove the overall significance of the primary outcome here. There really was no difference between groups in NIH stroke score change of less than 7, and no difference in terms of receipt of rescue therapy between 3 and 12 hours.
Yeah, so I thought that's what you said. So it's kind of like, okay, the hematoma expands, that sounds bad, but then 5% more strokes occur. So to me, that's like, that sounds like I probably don't want to use this unless I guess you're really forced to. Like, Nora, how often do you see this used? I'm sure you get called about this as a hematology oncology fellow.
Yeah, we do get called about it a decent amount. And the question is really whether or not patients need to go like for an emergency procedure usually that we're thinking about. And as Rahul said before, the kind of timing of both when the last dose of the DOAC was, as well as whether the procedure, if they need the procedure, can be pushed off until the DOAC is more out of their system. Those are kind of the two big questions. If they need to go emergently to the operating room for neurosurgery, then that the threshold to give the reversal agent is much lower than it would be otherwise. But, and they do point this out in the paper, the half-life of the reversal agent is very short, actually. And so they check the levels both before and after they administer it in the intervention arm, and they see for DOAC slightly different level decreases, but kind of across the board decreases. But the half-life is around 4 hours. And so there are cases actually where patients need to get multiple doses, though this is not FDA indicated. So just kind of an interesting other piece of this where there are probably some patients who decompensate further and the question is raised again.
Yeah. Any other comments on this before we get to the final points, Paul? Comments or concerns?
None than what was obviously stated. No.
Yeah.
Yeah.
Rahul,
I mean-
so how do you put this in context for the audience and any recommendations?
Yeah. I mean, to me, this is a good example of where your critical appraisal doesn't need a whole lot of bells and whistles. You can just decide what you think of the primary outcome and then whether that is really, patient-centered, associated with morbidity and mortality. And then if there is morbidity and mortality that the study drug is associated with, we should pay attention to that. So I enjoyed reading this paper because I think there were actually a lot of sources of bias towards a positive primary outcome. Like the primary outcome was changed during the study. The early stopping rule was made more permissive. So there was a lot of changes that, in my mind, made a false positive outcome more likely. But at the end of the day, the thing I'm most concerned about is the clear evidence of harm, that greater incidence of thrombosis and ischemic stroke. So I don't yet know if there is a population who would benefit from this drug, but based on this paper, I think it's not the population that they studied. So I'm going to give this 1 out of 5 hotcakes. Cannot recommend the use of this in the sort of unselected patient.
Okay.
This feels unprecedented. I feel like we just need to take a moment, but that's...
Well, I want it to be a little provocative because this is a big deal.
Yeah. Okay. So we're still going to be talking about, I guess, a drug that makes you bleed. Aspirin for, is it still fatty liver, Nora? What are we calling it nowadays? Because I think I hate this new name.
It's a great question, and one of the highlights of this article. So we are now calling it metabolic dysfunction associated steatotic liver disease, or MASLD. Paul?
Now, yeah, Paul, what do you think?
I love that I get to be the arbiter of names. No, I hate it. Like I do think it's my intention to create a moving target so that we as general internists just can't get it right, and it just becomes this very specialized niche level of care that we can't possibly interpret because the name is so tortured. Like I think this is just to make specialized care out of something that is largely cared for by lifestyle management. But maybe that's my own bias, and I could be off base with this.
Because Paul, didn't we talked about this? I thought we settled this with Liver Prof years ago, that it was no longer NAFLD, it was MAFLD, and we were baffled, and it was metabolic associated fatty liver disease. And I think that says what it is. It's great. And but now I guess we're going to this MASLD or whatever. Yeah, I don't like that.
Which
it's
awful. It sounds like calling someone a not nice name. So that's
from
what
Massachusetts.
I think of. Yeah,
somebody from Massachusetts.
You guys are so negative. I like it.
You can say it, Nora. We both lived there for a while. You were
assholes.
So negative.
But yeah, just for the wider audience, there was a nice consensus group guideline recommendation in late 2023 that does a good job of explaining the new terminology. So for those of us who aren't tuned into the day-by-day changes of this, that's a good resource, which we can link to.
And Nora, who covered this in the digest?
Yeah, so this trial, which was covered by Dr. Alyssa Mancini in digest number 52, looked at whether or not a baby aspirin, 81 milligrams daily, could reduce hepatic fat compared to placebo in patients with MASLD, or MASLD. And so just for a little bit of context, MASLD is one of the most common causes of chronic liver disease, and it can progress to fibrosis, cirrhosis, and even hepatocellular carcinoma in a significant proportion of patients. And there really haven't been many approved medications to reverse this process or prevent liver damage and inflammation, even in early stage disease, though it is worth noting that there was one drug that was just FDA approved in March 2024 for NASH, which is non-alcoholic steatohepatitis, which is an old name, and so brings up the question of how we're going to be bouncing back and forth between these names in the future in terms of our trial and drug indication. Paul?
Sorry, can we do a quick timeout? I'm hearing my cats lose their minds. I'm realizing because they got them locked in a room that's right by here. I'm hearing these two cats yelling, and it's an endless distraction. Give me 1 minute. I'm so sorry.
Okay.
I feel like we should keep this in.
I think we should probably keep this in.
Yeah, we definitely should.
Paul's doing our cat rescue during the show.
Yeah. Wow.
That's why we haven't had a cat.
Yeah.
We usually have a cat recording with us.
I know. I thought we did earlier, but I might have made it up.
I thought I heard meowing
right?
earlier.
Yeah.
Wow.
Paul, how are the cats doing?
Yeah, noisy idiots. I don't know. Like the one got locked in the room and the other one's just yelling for no reason. It's chaos here. I don't know. I don't know what's happening.
Okay, well,
Apologies.
Nora was about to tell us the top line results of her trial here of
Indeed.
aspirin for
Indeed.
Masold.
Yeah. Speaking of cats,
Uh-huh.
top line results of this trial. So this was a positive phase 2 trial. So it enrolled 80 patients. 40 patients were randomized to aspirin and 40 to a placebo pill once daily, and follow-up was done at 6 months. And the primary outcome for this trial was mean absolute change in hepatic fat content at that 6-month follow-up visit. So what are questions folks have about this trial to begin?
And, this aspirin reducing hepatic fat is not something I would have thought worked, but apparently they had seen this in a previous trial. I don't know if remember if they were specifically looking at this, but they had some reason to believe this might be the case, right?
Yeah, there's actually, I went down a rabbit hole with this and did not know any of this prior to reading about this trial. But there's been a decent amount of both preclinical and kind of mouse model data, as well as just observational data linking aspirin to a reduction in liver inflammation and also actually a lower risk of disease progression to fibrosis and hepatocellular carcinoma. There's a lower risk observationally of hepatocellular carcinoma in aspirin exposed individuals than in non-aspirin exposed individuals. And so there was one very small non-randomized observational study of 22 adults looking at aspirin in this context in Masold specifically, and looked at actually patients who were on aspirin or aspirin and clopidogrel, and found that these patients seem to have kind of stabilization or improvement in their liver disease.
Yeah. And I mean, we're going to get to the results, or more of the results, but I noticed that despite not losing weight, they lost hepatic fat, which to me is like, okay, that's interesting. Very interesting.
And it looked like the intervention group actually, I believe, was heavier. I don't know if it's statistically significant, but the intervention group actually seemed to be a couple pounds heavier than the control group.
Yeah, I don't think it was significant, but they were slightly heavier. And the difference in hepatic fat was substantial, at least just by percent change. So the mean absolute change for those on the aspirin arm, those 40 patients, they lost 6.6% of their hepatic fat by MRI, whereas in the placebo arm, they gained 3.6% hepatic fat. So it's actually a reversal of direction in addition to just a numerical significant difference.
So these were adult patients. Anything else important about the trial design? Just because I think it's interesting to talk about where this might go in the future as far as are we going to have to start putting people back on aspirin again, Paul? That's my question.
God, I can't. No, no one's getting more aspirin from me.
Yeah. I think that is one of the big questions remaining in this trial. But the patients were 18 to 70. They had established Masold. They did not have cirrhosis. That's kind of important to know. And were pretty young on average, mean age of 48, about even from a male-female perspective, and had a mean BMI of 34, as well as a mean hepatic fat content of 35%. The aspirin arm did have higher hepatic fat content than the placebo arm just at baseline. And the change in hepatic fat and the difference between placebo and aspirin was independent of BMI change or weight change within each group. And there was really minimal weight change in either group from start to finish.
Rahul, anything you want to weigh in on this trial? This was a positive trial. Anything that struck you as potential source of chance or bias?
Yeah. I mean, this is a really good illustration of how, in a small trial, you expect there to be some imbalances between groups just due to chance alone. And it's up to us to decide if any of those imbalances are, relevant as potential confounders that might influence the results that we're seeing here. So, you mentioned, Nora, about how the aspirin group had a somewhat higher BMI and more visceral adiposity. I spent a little bit of time trying to think about in which direction this could introduce a bias in the results. And I'm really not sure. The authors in the discussion say that might, create a bias towards the aspirin group doing better. And the only way that I could reason through that, and I welcome thoughts from other people, is if people in the aspirin group had sort of a higher fat content to begin with, they had more to lose, kind of regression to the mean idea.
Yeah.
That's what I was
That
thinking
was,
too.
yeah,
Yeah.
same.
Yeah.
Yeah, I feel like it presupposes that the aspirin does something in the first place, right? Like the higher your risk of something, the more effective an intervention is going to be for it. So this, I mean, it would have to, the bias would be as if the aspirin was actually, if I'm thinking things through correctly, was effective in the first place.
Yeah. Assuming the drug is effective, in which direction would this bias the results?
Right.
And this was all new territory for me. I didn't know that aspirin had this effect.
Love it. I would say, I think I give this a 3.5 out of 5. I very much like the incorporation of old medications. Big fan of aspirin, very controversial hot take there. But it just repurposing of these kind of older medications, thinking about things cleverly and using the like pathophysiology to think about how to improve outcomes is interesting. The trial didn't look at kind of patient important outcomes in any way. And so I think that's the main limitation. It's a small phase 2 trial. So we'll need to look at bigger trials and that are looking at patient focused outcomes.
Yeah. Paul, we do have to talk more about the liver, right? Because you have an article about naltrexone to talk about. And does it have a clever name? I
don't think it does. Naltrexone or the name of this? I don't think so. I think it's just a name of a paper, and God bless the authors for doing so. This is The Safety of Naltrexone in Patients with Cirrhosis by Thompson et al. And JHEP reports. So this is liver adjacent. I thought there'd be nice synergy here, and also because I use a fair amount of naltrexone, and a lot of times it does fill me with trepidation and nervousness. You always worry you're going to send someone screaming into decompensation, or you're going to send their liver enzymes through the ceiling. Even though the preponderance of data has been like it's a safe medication, like I know in my heart of hearts that is very unlikely to happen. And these researchers, God bless them, did further study on how safe is naltrexone in patients with either compensated or decompensated cirrhosis. And the latter group is one that especially makes me nervous, based on looking at drug-induced liver injury specifically. So not just liver enzymes, but the likelihood of whether or not a change in enzymes is from drug-induced liver injury. So initial thoughts or questions before I move on toward exactly what they did and what this looked like.
Yeah, I know this always comes up, Paul. I think people say, like, if the liver enzymes are greater than 3 to 5 times the upper limit of normal, it should give you pause and maybe not give naltrexone altogether. I know that's not exactly what this was looking at, or where it'll pop up a warning, like if someone has cirrhosis, they'll say, hey, are you sure you want to give this? This person has cirrhosis. And when I've looked this up on that liver tox website, it didn't seem like they really believed naltrexone caused liver injury. They thought it was more just like there's too many factors, like patients that would be prescribed naltrexone have a lot of other reasons for their liver to be, like a hepatitis or other substances that could harm the liver. That was kind of my take. Is that kind of what the authors were presupposing here as well?
So this is exactly the issue, Matt, is that once upon a time, there was a black box warning for naltrexone causing hepatotoxicity. And this is based on an old study that actually where the patients were given like these whopping doses of naltrexone that are not used in common practice. I think it was something like 300 milligrams is where they saw the effect. And for reference, it's 50 milligrams. And the authors of that study even did not show actually any changes with like the normally dosed naltrexone, but still based on this. There was this black box warning that was since rescinded, and now there's like this vague warning, like just careful with patients with liver disease, where meanwhile, those are the patients that you're using the medication for. So as a result, everyone is just kind of white knuckling as to whether or not to prescribe it. So the authors of the study are hoping to kind of get around this and be like, look, it's fine. So let me tell you what they looked at. So it's a retrospective study of about 3,000 patients. They looked at this data set, which for the record, by the way, not a bad name. This is Veteran Outcomes and Costs Associated with Liver Disease Database. So not bad. They went back and they looked at veterans enrolled from 2008 to 2021 that had a diagnosis of cirrhosis based on either an inpatient diagnosis or 2 outpatient ICD-9 codes, which apparently has great predictive value for true cirrhosis of the liver. And they were looking at new exposure to naltrexone after a diagnosis of cirrhosis, and they could not have had naltrexone exposure in the prior 12 months. And so after these patients were started on naltrexone, they then had to have labs within the first 3 months after exposure, because that's the period you're most likely to experience drug-induced liver injury. And then they went through and used this thing called the Roussel-Uclaf causality assessment, or RUCAM criteria, to determine whether it was likely or not that the naltrexone, if the patients did have an elevation in liver enzymes, is it likely it was caused by naltrexone or something else? And it's a really important, like, not to belabor the point, but if someone continues to drink, I have news for you, their liver enzymes may creep up. So naltrexone is not the only cause of an elevation in liver enzymes in someone who is on naltrexone. There are lots of other things that can do it, new medications, and also continued alcohol use being probably the most important exposure. I had not heard of this RUCAM criteria. If I had, I forgot about it. Is this something we've talked about before, or anything you guys are familiar with?
No, I had not.
Yeah, I think we knew about the R factor, which is this calculation to determine whether or not an exposure is hepatotaxic, cholestatic, or both, or some sort of mixed picture. And that's part of this RUCAM criteria. But there's other stuff like, is this a known hepatotoxic medication? Did the patient have re-elevation of enzymes after a repeat exposure? There's lots of things like pregnancy, other, like, it's a whole lot of criteria to go along with this. So, and this was all done through retrospective chart review. And let me get to the take-home points, because I'm talking too much now. But the point being is that for those patients that did have an increase in their liver enzymes, whether from baseline or just above whatever the normal range was, there was no determination that any of the patients were likely to have to be a drug-induced liver injury from naltrexone, is the long and the short of it. It was determined to either be, I want to make sure I get the wording right. So
yeah, Paul, I have the RUCAM scores. They go from greater than or equal to 9 is highly likely that it was drug-induced liver injury. And then it's excluded if it's 0 or less. Obviously, I don't know how you get less than 0. And if it's unlikely if it's a score of 1 to 2. Mm-hmm. And it looked like all these patients fell in that range, right?
48% were excluded, 52% were unlikely. And if you're a math wizard like we all are, that equals 100%. So, like, not. So these are patients, it was unlikely for all these patients, this was not the naltrexone that caused it. So I won't get into the specific numbers because I don't think they're all that important. There were patients that had bumps in their liver enzymes. It was unlikely to be a drug-induced liver injury from naltrexone. Importantly, the patients that were included in the study, there was a subset that did have a history of decompensation, whether it was encephalopathy or varices. So, like, these are people that had significant liver disease who did not have harm from them attributable to naltrexone. So it, again, just reaffirms that this is a medication that is safe to use in patients with liver disease. I think if someone is having an acute liver injury, I might hold off. Mm-hmm. But otherwise, I think you should feel fairly comfortable using it. And we don't have to be quite so militant about sort of monitoring enzymes, getting too womped up about things. Because you'll see there have been studies that have looked at this, that patients, even with or without underlying liver disease, who start naltrexone, their enzymes go down if they have comorbid alcohol use disorder. So the patients, the enzymes get better because they drink less, because naltrexone is a good medication, is the takeaway point you should make from this.
Did you want to give it a hotcakes rating, Paul?
I do. I'm going to give it a 4. It would be a 5 because I do like anything that makes me feel better. But I will say, this RUCAM criteria done in the setting of retrospective chart review, I wonder if there's not data that may have been missed. I think some of it's fairly specific stuff that they ask for here, including things like drug rechallenge that have their own specific scores with it. So I wonder how precise you can be when you just have a resident mining chart data and kind of doing this RUCAM analysis. So I think it's consistent with lots of other studies and makes me feel good about things. But there's so I'm just going to deduct it 1 hotcake just because I'm not exactly sure the criteria they used, how exactly perfect it could be, but I think it's still a pretty great paper.
You don't think that resident did a good job, Paul?
Yeah, wow.
I think that resident did a fantastic job. They should be proud of themselves. I wish they were my resident. I wish they were my friend.
Nora, did you have anything else to say about this? I think I cut you off.
Oh, I was just going to ask, will you extrapolate this to IM naltrexone as well?
Yeah, I think it's ostensibly because you're avoiding the first pass metabolism, maybe it's even safer. I will say it was a very small percentage of patients that got IM naltrexone in the study. They mostly got oral naltrexone, which I thought was very interesting.
Yeah.
But I think I would be comfortable making that extrapolation for sure.
Okay, and now for some hot takes, and we will go quick with these. First up, the FDA has approved a new medication for uncomplicated urinary tract infections in female patients. This is Pivmecillinam. Paul, have you ever prescribed this before?
I have not, and I thought you were going to ask me what I thought about the name, and I think it's a terrible name, by the way. Like it sounds like they took 4 antibiotics and just smashed them together, which is just it just seems lazy.
Well, yeah, Pivmecillinam is the prodrug for Mecillinam, which is, I guess, the actual active antibiotic that it gets converted to. And actually, pivolate is generated, Paul. And pivolate is apparently a compound, which I had never heard of before reading about this, that can bind to carnitine and is excreted in the urine, Paul, and it can cause carnitine deficiency.
Sure.
Sure, you knew that, of course.
Yeah,
And
but I mean, yeah.
apparently, other drugs that can generate pivalate are valproic acid and valproate. So you got to be careful prescribing this if patients are taking that. But I think that's going to be a small subset of patients. But basically, the good news is this is in addition to nitrofurantoin, trimethoprim, sulfamethoxazole, phosphomycin. This has been listed in the IDSA guidelines. It just hasn't been available in the US, so I've never prescribed it. But it's a welcome, I think, addition. It's a beta-lactam antibiotic. It's taken 3 times a day for 3 to 7 days. And I think this will be useful. And I think this will be something that we actually prescribe if the cost is not too much. Anyone else, any comments or concerns, questions about this?
Any big contraindications? Do you have to renally dose it? Is it like, other than making sure that the patient's eating a diet rich in carnitine? Is there anything else that we should be concerned about before we just fire this thing off?
No, there's just some interesting things. I mean, definitely people that have allergies to beta-lactams, that would be one of the big ones to look out for. Nausea and diarrhea are the common side effects. And I sort of told you about some of the drug interactions. If the mother gets this and then the newborn has the newborn screen, it can cause a false positive for isovaleric acidemia, which I thought was pretty cool, but otherwise, not too much. I think this will be something that's relatively easy to prescribe and probably will be prescribed once it's available, especially if patients, can't take trimsulfa and nitrofurantoin is not an option. This was
genuinely
covered.
exciting.
Yeah, this was covered by Dr. Alyssa Mancini in Digest number 53. And, that's how I heard about this. And thank you, Dr. Mancini, for covering this. So next up is Cefepime versus Pip-Tazo. Rahul, tell us about this.
Yeah, so the Cefepime versus Pip-Tazo debate continues. So this hot take is about a study by Chandaraj and colleagues that was published in the May 2024 issue of JAMA Internal Medicine. And this study was designed to test the hypothesis that empiric therapy with Pip-Tazo for patients with sepsis, but without a clear indication for anaerobic coverage, would, when compared with empiric therapy with Cefepime, be associated with a higher 90-day mortality. Okay, so the authors thought that Pip-Tazo would be associated with a higher 90-day mortality than Cefepime. And the idea underlying this is that the depletion of anaerobes leads to worse clinical outcomes. Anaerobes, you probably are familiar with the gut microbiome, very important. So there's some preclinical and observational data that support this idea. I had never encountered this previously, apart from the sort of general idea that broader spectrum antibiotics disrupt the gut microbiome more than narrow spectrum antibiotics. And in terms of the top line results of this paper, this was a positive study. The authors used a shortage of Pip-Tazo in the University of Michigan health system as an opportunity to do a natural experiment. And they found that among patients with sepsis without an indication for anaerobic coverage, the use of Pip-Tazo was associated with a 5% absolute increase in mortality at 90 days compared with Cefepime alone. So are there any potential sources of bias that people could anticipate affecting the results of this study?
Yeah, I mean, Rahul, I got this from you because we were talking beforehand. I mean, the people that get anaerobic coverage, it tends to be maybe sicker group of people. So that could maybe make it look worse that the people who receive Pip-Tazo instead of Cefepime, maybe they got that because people were more worried about them.
I love it. I mean, that's just using your clinical intuition to guide your critical appraisal. Absolutely.
Your clinical intuition.
No, I mean, I was not the one who came up with that idea, but no, I mean, you bring up an important point, though. I mean, despite this being a well-done target trial emulation, nevertheless, it used retrospective observational data, which is vulnerable to bias. And unfortunately, there is evidence of confounding by indication in this study that threatens our interpretation of the results. I'll keep it brief because this is just a hot take and people can read more in the show notes, but the raw data didn't reveal a mortality difference during the shortage period. And these results are kind of at odds with the findings of the recently published ACORN trial, which we discussed back in Hotcakes episode number 414. And that found no mortality difference at 14 days. The authors of this study also looked at mortality at 14 days and found no difference at that time and found that the mortality difference only emerges later. So we'll put in the show notes some extra reading, but Josh Farkas, was very quick on the draw with a blog post about this paper, kind of discussing some of the mechanistic plausibility of a mortality difference related to a treatment decision for critically ill patients arising after the acute period. I'm not sure if that makes mechanistic sense or not. The authors did a lot of sophisticated analysis to try and probe this. And, ultimately, I think it's really unclear whether this should be practice changing for that reason you said, that I think physicians often prescribe anaerobic coverage when patients appear sicker. So for me, this was a great read. The methods section of this paper, it's like, a fine wine. You could curl up on the couch and just read this. For me, this is a 3 out of 5. Because it's a good paper, well done study, but I'm not sure that it's persuaded me that confounding by indication doesn't explain these results.
Yeah,
you're like my 10th grade English teacher.
Mm-hmm.
Really great work. That'll be a C+.
This whole literature about Vanco plus Pip-Tazo or Vanco plus Cefepime, and I find that it's been a little bit back and forth on, like, first they told us all to stop prescribing Pip-Tazo, then they said it's okay to prescribe it. Now we're back to Pip-Tazo might be bad with this one, but there's, at the limitations you just said. So I think we can still prescribe Pip-Tazo if we think someone needs it.
Wait, because I've lost the thread here because I don't do inpatient stuff anymore, but isn't Cefepime causing neurotoxicity and
right
acute encephalopathy as well, in addition to not tanking the kidneys, which it might be now?
Yeah, well, Paul, if you go back and have a listen to episode 414, you'll hear a very erudite discussion of the topic. The ACORN trial did show that Cefepime, compared with Pip-Tazo, did lead to more delirium and coma. There were criticisms of that study for being open label, which might affect our adjudication of, neurotoxicity. But yeah, best evidence we have to date suggests that at least with respect to neurologic outcomes, Cefepime is probably worse than Pip-Tazo.
Yeah. So again, Paul, I'm still a little confused on this, but
I'm starting to think if you use either combination, you're probably treating a patient who's sick who may not do as well as somebody who's not.
There we go.
I'm just a simple country doctor, Watto.
All right, Nora, should we decolonize patients in nursing homes and hospitals? Can you tell us?
Yeah, I mean, I would say the pendulum is swinging towards decolonization overall. There have been a number of studies over the last year or so looking at decolonization using chlorhexidine in combination with nasal swabs containing iodine containing compounds. And we're going to talk briefly today about an article that was covered by Dr. Laura Glick in Digest number 53. This looked at hospitalizations and MDRO, or multi-drug resistant organism colonization and infection, as well as cost associated with decolonization. This was data out of what they described in the paper as a quasi-experimental quality improvement initiative in Orange County. And I thought this whole episode, we've had some really great acronyms. Maybe my favorite was SHIELD OC of the day.
That's pretty good.
Yeah. So I'm curious what Paul's thoughts are on that.
Can I tell you? So God bless ID, but they kept it honest.
Yeah.
Like that is a good acronym.
Right?
Like it is solid. It tells you what you want to say. They didn't try to shoehorn in letters. So I am proud. I think it's a remarkable study, but also the title itself is just A+, 5 out of 5 hotcakes.
Yeah.
And we probably can't because of copyright, but I would love to just drop in that California song from the TV show, the OC.
Yep.
I thought the same.
It's playing in my head now.
That would be from the band Phantom Planet.
Yeah.
Which I believe had Jason Schwartzman as a drummer.
What?
Well, I think you're right.
What you will.
I think you're right.
Wow.
So Nora, top line results, was this a positive trial?
Top line results, this was a positive trial. They looked at a bunch of different outcomes in this. Taking a step back, they looked at 19 nursing homes and LTACs and 16 hospitals in this quality improvement initiative. And they had a relatively short phase-in period after a 25-month baseline period, followed by a 25-month intervention period. So that's the decolonization protocol period. And the intervention at the nursing homes and LTACs was different than the intervention at the hospitals. The interventions at the nursing facilities involved using chlorhexidine bathing on admission and then using chlorhexidine for all routine bathing following that. And they actually mentioned kind of the bathing frequency at nursing homes is approximately 3 times per week. And at LTACs and hospitals, it's typically daily. I actually don't think I knew kind of how that breakdown worked between nursing homes and LTACs and hospitals. So that was kind of an interesting piece of information. I don't know if you guys knew that either.
My thought about this is that chlorhexidine bathing every day doesn't seem like it'd be using like Dove soap or something. Like it seems like it would be very irritating to my skin, but I don't know.
I will say they looked at adverse events in this study, and there was mild skin irritation in like a handful of cases, and then one adverse event, which was soap in the eye. So do with that what you will.
So that doesn't seem that surprises me. I would have thought everyone was just itchy perpetually.
Yeah, I do think it can cause a mild skin rash in folks who have some kind of contact dermatitis to it. And so the only other piece of the decontamination at nursing facilities was they also did do these nasal iodophore swabs on admission and then alternating weeks. And then hospital decolonization was targeted decolonization, so not universal decolonization. And so that was just for people who were in non-ICUs and in contact precautions. And so top line results for this, looking at the decolonization protocol, they saw a decrease in MDRO, that multi-drug resistant organism colonization in all of these facilities. They saw a decrease in MDRO positive clinical cultures as well. And then they also saw that comparing participating hospitals or participating facilities to non-participating facilities from baseline to the intervention period, they saw decreases in the participating facilities of all of these, as well as of infection-related hospitalizations and cost. But in the non-participating facilities saw actually increasing cost and increases in a number of these. So kind of overall trajectory improving with decolonization.
Yeah, I was telling you off air, I feel like if doctors knew you wouldn't have to put on as many gowns if patients were having this done, then you'd have like everyone would be behind it because so many patients, I'm in the hospital this week and so many patients, like most of my service, I have to put a gown on to go see them, which is just annoying.
Yeah, it was interesting. I don't know what you all make of this, but like the adherence to the protocol, to the decontamination protocol, was lower in hospitals than in nursing homes. I don't totally know how to explain that.
People
just more acuity. Control. Yeah, I'm not sure.
I mean, like
stuff going on.
When you're backed up in the emergency department, like you don't know when beds are going to open up. Like nursing homes are very much able to control when someone actually comes in, and things are protocolized in a way that I'm not sure that happens in more acute settings. So that tracks to me.
Yeah. So, any other final thoughts on this one? I think for interest of time, we should get on to Paul's next one, talking about microplastics. I guess they're another scary thing. MDRO is scary, but microplastics, Paul, maybe even scarier, right?
Oh, I don't know. Yeah, I mean, it seems bad. Yeah, so I figured I'd talk about this just because it's been in the lay press a lot. So I thought I was sort of duty bound to read up on it a little bit. So I mean, as you all know, the world is horrible and on fire, and we're all eating poison all the time. So the point of this study is, you've been hearing more about microplastics being found, and nanoplastics specifically, these N and the Ps being found in various body parts and organs and things. And it sounds bad, and certain studies have shown that it is in fact bad, but there have not been studies that have shown the presence of microplastics being present in atherosclerotic plaques causing disease or making you at higher risk for death or heart disease or stroke or that kind of stuff. So basically what the authors did, this is an Italian study taking place at 3 different sites. So patients who are slated for endarterectomy for high-grade asymptomatic carotid artery stenosis. I just want to make sure that I'm clear about that. So they have greater than 70% stenosis that are asymptomatic of the carotids undergoing endarterectomy. So these are patients who already have probably significant cardiovascular risk, underwent biopsy of the plaques in those arteries, and then they evaluated them for microplastics. And then they sorted what they found in 2 groups, those who had microplastics and those who did not, and then observe them over time. This is a prospective study from 2019 to 2023, I want to say. for a composite endpoint of myocardial infarction, stroke, or death from any cause. And what would you all suspect? Microplastics in in atherosclerotic plaques, good, bad, indifferent. What might you imagine would happen here?
Paul, this is something I'm scary about ever since I learned that like most of us probably have lots of microplastics invading our body. But I thought the comments to the author, the letters to the author, Rahul, that you pointed out to us were pretty interesting. My take on that, Rahul, was they were suggesting like maybe these microplastics are there for other reasons. It's hard to prove causation, and could it even be just the coronary stents or the intravascular stents people are getting deployed that could be the source of microplastics? But Rahul, what do you think?
Yeah, I think I remember the feeling of everybody in my circle kind of freaking out when this paper first appeared online, because it sounds terrible. It sounds scary. It sounds like, oh, we are all going to, die of microplastic induced vascular disease. But I think that the letters to the editor, it can, in general, a great learning experience, reading the letters to the editor on a paper and writing letters to the editor. But in this study in particular, they sort of pointed out one way in which, okay, this could have been something that was causal. This could have been something that was associated with the outcomes that were seen in a non-causal fashion. And I like to try to go through that exercise myself to sort of see if I can at least, give words to a non-causal pathway. And the letters do a good job of that. We can link them in the show notes.
So, Paul, should we be panicking? Should I remove all the plastic from my house?
Well, as is our way, we didn't actually get to the end point, which is bad, by the way. So the answer to the question is microplastics in the plaques actually, when they were present, you were more likely to have a heart attack or stroke or die. So bad. I don't know. I'm with Rahul. I don't know that we should panic necessarily, because mechanistically, I'm not entirely convinced that we can say there's a straight line between the microplastics and these events themselves necessarily, and whether or not a marker. So one of the letters that I thought was particularly interesting is this idea. So because where you get these from are like, how do they get in the plaques themselves specifically? These are found in the air that we breathe. They can come through the skin. You can eat them. And what happens is they may even be present in the macrophages that are in these atherosclerotic plaques. So the macrophages may have already ingested them someplace else in the body and then made their way to these plaques, and that's why we're seeing them there. And it's not necessarily a cardiovascular thing. It's just that they already happen to have them, and who knows what to do with that. Or these patients already have higher degrees of inflammation. It's just there's a lot of various mechanistic stuff. I think a rabbit hole I went down that I was telling you guys before we started recording is that exposure and extent of exposure matters. And the patients that are at risk from complications from pollution in general, which plastics is one potential concern, are vulnerable patients. So the people who do not have a say as to whether or not manufacturing facilities are near their homes, or who cannot get away from polluted waters. So these are folks that may have a lot of intangible risks to their health in addition to sort of these microplastics. And these microplastics just may be a marker for potentially other exposures as well. So I think there's lots of ways to look at this. I think it's probably incontrovertibly bad to have them in us, but as to whether or not they are a direct cause of disease or a marker of things that cause disease, I think still remains to be seen. I think we should panic about everything. You know me. But I don't know what we're supposed to do about this other than be like, yeah, sounds bad, and we'll keep studying
Seems bad.
Yeah. I try not to drink out of plastic bottles. That's kind of my thing.
That's the funny thing. The people who are probably least at risk for this are like, yeah, maybe I'll just change to like a steel water bottle as opposed to plastic. I'm like, okay. Okay, great.
And then I fill it from a giant 5-gallon plastic jug at my work. All right.
Fresh from the Skullkill.
Yeah. So, speaking of bad ideas, Paul, Pax-NO-vid, I say Pax-NO-vid, Paul.
Oh, snap, Watto. They are not coming back from that.
Okay, so we've talked about Paxlovid, which is nirmatrelvir, ritonavir, and Paul Sachs wrote one of his blog posts on the rise and fall of Paxlovid, and I just wanted to highlight that I feel like this is where we've gone wrong, Paul, as a healthcare system and we've lost some trust over the past couple years, particularly around the COVID-19 pandemic. And this Paxlovid, I'm just going to say the trade name since we're definitely not promoting it with this piece. Since June 2022, there were interim results from this EPIC-SR, the standard risk trial with Paxlovid, saying that it didn't work for people that were lower risk, who had either been unvaccinated or vaccinated with at least one risk factor. And they were just looking to see if it shortened duration of symptoms, and it didn't. And so we've known since June 2022 that it didn't. And we reported on that on Hotcakes in August 2022 based on that release, and we were waiting for the study. Paul, when do you think the study was released?
I have to assume like early September 2022. Is that?
They waited until April 2024. So
Huh.
the clinicaltrials.gov protocol, they messed around with it a little bit in December 2022. Then in August 2023, they updated the results. And then it wasn't until April 2024 that they reported the results in the New England Journal of Medicine. This was a negative trial. It didn't work to shorten the duration of symptoms. And all during that time, in 2022, the World Cup, the World Series, watching those, they were advertising, ask your doctor about what treatment you can get for COVID. And then this year, if it's COVID, Pax-NO-vid, and they're showing people that look like standard risk people to me. And, I think it's just gross that we did not, that this medicine was just kind of pushed out there as if it's for everybody, if it's the oseltamivir or the Tamiflu equivalent for COVID. And I wasn't as privy to the oseltamivir Tamiflu results, but I would love to go back and look at those now too and see how significant that is, because I feel like this drug has been a little bit misleading the way it was marketed and the way that the results have been released. But any other comments from anybody, Rahul or Paul?
Yeah, I mean, I'll just give voice to a perhaps unpopular opinion. There was a time when I was really, on board. I was really glad that a medication existed to reduce the risk of hospitalization and death among high risk unvaccinated patients, just to put that out there. But, subsequent to that time, the world and the nature of COVID-19 and the level of immunity in the population have really changed. And now in the current era, the benefit of using nirmatrelvir ritonavir is much, much lower than initially. So there was a time when I was very glad that, in patients who couldn't access vaccination, either because of supply or, personal preference or medical contraindication, of which I don't really think there are any, it was good to have an alternative. But now, now we're at a point where many of my friends and colleagues are sort of asking, well, why did Pfizer sit on these data? And, the cynical interpretation is that it's just to make more money. But the thing that really troubles me is that, is there any legal or regulatory stop to them doing this? And it makes me kind of wonder, what should we be advocating for, and what should we be demanding of our, health systems to prevent things like this from happening in the future?
Yeah. I mean, we want drug companies to make drugs that do help people. And
Yeah.
I think, this was tricky because COVID went from something that was really virulent to something that's now more like a common cold. And so the risk benefits have all changed for all sorts of things. But I do think that this is why we do Hotcakes. Part of it is to try to follow medications and studies and figure out whether or not we should be doing things or not. And there is another trial, this panoramic trial that Paul Sachs mentioned, still enrolling, and they're still looking at nirmatrelvir ritonavir and also molnupiravir as well in those. So, we'll see, but I'm still just not hopeful, especially with COVID being just less virulent nowadays. So,
And it's not a fully benign medication. Like that's
Yeah.
the fact that we're stopping statins, we're, dose adjusting seizure medications. If that, and oftentimes I see that due diligence is not being done. It's just handed out like candy. So there's no real talk about med-med interactions. I don't see renal dosing happen sometimes. Like, so in a certain, the side effects and the potential for rebound are not insignificant. So I might feel a little bit less outraged by this if this was like an otherwise entirely safe and
Yeah.
benign medication that maybe potentially help people. Instead, like there's potential for real harm, and the benefit well oversold as far as I can tell. Now, in these stages, as we've talked about, I think I'm with you, Rahul, early on. Like, yes, 3 cheers for Paxlovid, it seemed to be making a real difference. But as things evolved, and the fact that it's still being marketed as aggressively as it has in the setting of it's not a fully safe medication that is not seemingly accomplishing what is being promised, I think it becomes a little bit grosser.
And
so I'm with you.
Paul Sachs was much more diplomatic than I'm being here, but interesting just, reading the email from his friend that he includes in the blog post, and also the comments from his readers below, who are most of his readers are like smart ID doctors, and the comments are interesting. So definitely we're not the only ones that are bothered by the way that this all went down. But Paul, I think we have to end the show at this point. So let's get to an outro.
This has been another episode of the Curbsiders, bringing you a little knowledge food for your brain hole.
Yummy.
Who's going to do it? Oh, strong. Still hungry for more? Join our Patreon. Get all our episodes ad-free, plus twice monthly bonus episodes at patreon.com/Curbsiders. You can find our show notes at thecurbsiders.com. And sign up for our mailing list to get our weekly show notes in your inbox. This includes our Curbsiders Digest, recapping the latest practice-changing articles, guidelines, and news in internal medicine, edited by our own Dr. Nora Taranto.
And we're committed to high value. Practice-changing knowledge. And to do that, we need your feedback. So please email us at askcurbsiders@gmail.com. It also helps when you subscribe, rate, and review the show on Spotify, Apple Podcasts, or on YouTube. A reminder that this and most episodes are available for CME for all health professionals at curbsiders.vcuhealth.org. A special thanks to our wonderful guest co-hosts for this, Dr. Rahul Ganatra and Dr. Nora Taranto, and to our whole Curbsiders team. Our technical production is done by Podpaste. Elizabeth Proto runs our social media. Jen Watto does our Patreon. Krista Chu moderates our Discord. Stuart Brigham composed our theme music. And with all that, until next time, I've been Dr. Matthew Frank Watto.
I've been Dr. Rahul Ganatra.
I've been Dr. Nora Taranto.
And as always, I remain Dr. Paul Nelson Williams. Thank you and goodbye.